that when they were trying to resuscitate, you know that drug they went to give IV, that is what escorted them. That compression that you did, that is what killed them. So, did those participants really, have they ever participated in resuscitation in the presence of relatives, or they were just giving their view?
Thank you so much. Sharing the result is very important. Mine could also, now, my question is pretty big. How do you get to handle the issue of confounding factors when you are taking your data or collecting your data? Confounding factors like emotions, culture, religion, those are some of the things which always are in our power. So I don't know when you are collecting your data, how will you handle it? Thank you.
If we let them take those questions, then we go to the next presenters. Other questions can come during the break, isn't it? Yeah, so we will start with just the way you are seated, the way you present.
So I will start with question number 1, concerning the cold chain. In Rongai sub-county, yes, it was included in storage of vaccination, and in Rongai, they were using the new fridges from the UNICEF, which they store the vaccines very well, and in some few facilities, which they did have the new cold chain fridges from the UNICEF, they stored well. I was able to see, and on the vaccines were available at the facilities, and concerning the way the storage would affect the efficacy of PCV10 vaccine, I was not doing the effectiveness of PCV10 vaccine, but I stuck to my objective of uptake of PCV10, and so I was not able to do effectiveness. I did on uptake. That's what I did in Rongai County. And on storage, they were using the new KP filters from the UNICEF, which stores vaccines. Thank you. And on exclusion criteria for the under-5s, for the caregivers who were mentally sick, and for the children who were sick, yes, it's a good input, I accept. And for the next time, we will include, because those children who are sick, could be they were suffering from pneumonia, and we needed to look at the status of vaccination, if they are fully immunized, if they have gotten all the PCV10 at 6 weeks, at 10 weeks, and at 14 weeks. So I agree, it's a good input. Thank you.
Regarding the first input for the case studies, I need a little summarize of the presentation, so maybe if I give my specific objective, will be clear on that. My first specific objective was to examine the influence of sexual reproductive programs on rate of teenage pregnancy and STI on improving childhood outcomes, to investigate the change in resources and ability to midwives on improving childhood outcomes, and thirdly, to assess the effectiveness of nutrition education programs targeted at parents on improving childhood outcomes. Regarding what to do with the findings, I'm a young tech, so I'm planning on presenting everything to my facility. We start at our facility level, that is Nyahururu Referral Hospital, and hoping and God willing, we'll also expand to the county level. Then we'll see what happens from there. Thank you.
Okay, thank you. So the first question was on one of the accident-related factors that I mentioned, which was advanced specialized training on resuscitation, and how that had effect on the dependent variable, which was the implementation of family witness practice. So during the study, we did not assess BLS and the CLS individually and how each individually contributed to the dependent variable. But we wanted to check whether there was a relationship between any other training on resuscitation apart from the basic training that we are normally taught during the nursing curriculum, because advanced training increases skills in performing resuscitation, because usually resuscitation medicine is dynamic and there are new things that are usually introduced, some are updated. So that in itself was a way of improving his resuscitation skills and how that helped in perceiving whether they are self-confident or not. So we just looked at them, both of them together. So the second question was whether they actually practice witness resuscitation or were just living the experience. So from the data we found, or from the experience from where I work, family witness resuscitation, it varied among nurses. Despite it having been introduced over 3 decades ago, actually there are some of the respondents who actually had not heard of it. So what happens is that a place like an emergency department realize the family comes with their loved one who was involved in an accident and need urgent resuscitation. And what happens is that some will send them away, then call them to give them outcome, while others will want them to just stay around and see what transpires. So from the study, there are those who actually practice it, but there are those who do not practice it. But the idea from the professional association, for example, American Heart Association, or emergency nursing, they also recommend that family should be given an option. So what is important to note that institutions need to develop like institution policies to guide on how to handle the family who opt to witness, so that such fears like the one we are raising, that some may think that it's the intervention that you are doing is what was the ultimate demise, which may not be true. So there should be institutionalized policies and families should be given the briefing to try to explain for them what actually transpired. I think I've answered.
Thank you very much, presenters. Very good presentation from Wasingishu, Nakuru, Nyahururu and Siaya. You can have your seats. Thank you, Lorna. Thank you, Felistas. Thank you, Andrew and Bilha. Felista said she's a young tech, but I want to encourage you. You've started well. I'm sure by the time you reach like the age of 9, you'll be a guru in this. So you've started well. Get encouraged. Now we are going to have the next speakers. And I remember telling you that the first presenter had opted to do the poster presentation. That is, the topic is, it is not only about salary but also organization culture, which was to be done by Evans Kasimai. But due to public demand, he is going to present to us. So we are going to, he will be the first one in the next round. And then we will, number two will be Javan Oche. Javan will be the next one. And then Turaila will be the third one. And we will finish with Anne Musyoki. So the rules stand 10 minutes each so that we leave time for the questions. So when I lift the hand, you know that it is commuting time. So Evans, the stage is yours. 10 minutes starting now.
Wapate sura peke. Ema sura staki hizo. Focus. Zoom out
Thank you so
kidogo
much for the opportunity.
hapo, kitu kama hiyo. Sawa.
Alafu nikae ni count hadi 8. Ni count hadi 8.
So, my focus on not only about salary, but also about the examining the impact of organizational culture for career leading among. If you ask this question, how many of us have exit the country, travel to other countries, or for those of us who are lecturers, how many of you have had the students travel to these countries outside the country? By show of hands. Yeah, just like this. Shortage of nurses has become as a taking time bomb. And this is basically due to, due to various factors. If you look at the maps you see on the wall, migration of nurses basically happen mostly in low and middle income countries to stronger and bigger countries. And most people have thought that nurses exiting these countries has something to do about only salary most of the time. Next slide. But it's not only about salary, but as well about organizational culture. And about the crisis of nurses happen basically because the world is facing a lot of challenges. One, there is an aging global population who demand more nurses. We also have population growth, especially in our countries, especially in Africa. And there are also upcoming chronic diseases, pandemics, and also burnout when nurses leaving organizations, shortage of nurses. All these put together have made shortage of nurses become a ticking time bomb as put by the World Health Organization. And nurses leaving their countries have so many impacts directly on the patient care, the quality we offer to our patients. And we lose a lot of experience. These countries where the sending countries and our sending countries lose a lot of experience from these nurses. We take a lot of time to be regained back. Especially, for example, a nurse who is an experienced living care. It takes a lot of time to regain back that experience. And also, impact of this can include also direct costs, especially countries through their education systems, training, and when these nurses leave, they leave a lot of quality. So, organizational culture. What is organizational culture? It's defined as a system of shared values, beliefs, and morals that produce norms and behavior and to put it simply, it is how we work within here we basically included articles which are private articles, and we excluded editorials, letter opinions, and many other, as you see on that. This was our results on the Christian side. In our initial search, we found about 2,306 articles and 2 different levels of screening, title abstract screening, full text screening. We finally included 30 articles. In terms of the studies of the articles, it was conducted between 2006 and 2023, with the majority of the studies done in the past years. Our major variable, which we were looking at, is how are nurses living their countries of origin. And the green, the upper green, is the average of the global, how nurses exist or intend to exist their countries. And we found that 50% of nurses, like are seated here, 50% of us do not want to work in the countries of their origin. They want to exit to work in the other countries. The yellow one are studies which had lesser than the 50%, and the studies which are red are all studies which are higher. And you can see from the chart we have as high as 82% of nurses in some countries, for example, in Southern Korea, and we did find studies majorly in Africa and in Kenya, but mostly in other countries. And it shows that nurse turnover, the nurses exiting their countries, is so high. On our thematic analysis, what are these factors? We say it's not about salary. So, what's it? And we, in our analysis and thematic analysis, we found major 5 factors which exist in the countries, and one is organizational culture. The type of organizational culture. And majorly is we put into positive and negative. Sorry for that, we don't polish it well, but listen to what I'm saying. Positive organizational culture is where nurses are valued. Me as a nurse feeling I'm valued within a system. Me being respected within a system. Me being given that opportunity to prosper academically, professionally. And without these things, nurses exist an organization. Being able to work collaboratively as a team, having teamwork. And another thing is on organizational climate. Climate is the perception. How do I see this hospital? How do I see the rules within this hospital? Are they faithful nurses? Are they against nurses? And how do, even the morals, how do conflicts handle? Is there fairness? As the last part, which is justice. Is there fairness in terms of promotions? Is there fairness in things within those hospitals? And also on the part of leadership, when nurses when a leadership within a system is democratic, is objective, is supporting the nurses, and the rules and policies also favor the nurses in terms of academic opportunities, and if the organization is supporting nurses, definitely nurses are retained more within that system. And this is just those parts which organizational culture affect, which points organizational culture affect in terms of nurses living, which include job satisfaction, organizational sensitivity, and other parts. So, in conclusion, nurse managers and hospital managers should strive to continuously monitor and build a positive, otherwise known as magnet. Magnet is something which is able to attract, to pull and to attract. So we should all the time be able to build such kind of a system within our hospitals which favors everybody to stay. And for us to be able to retain nurse workforce and raise quality of health service delivery within our countries and within our hospitals. Thank you very much.
I can see why it was on public demand. He has laid it. Was wishing their governors to be here to listen. Now,
I don't know if I should say a student nurse or a pre-intern or an intern. I mean, I want to appreciate your presentation, my brother Evans. That was a good one. So I'll be presenting on cancer care, financing, policy and advocacy. As we all know, one of the key things that we are looking at when it comes to preventable diseases in Kenya is cancer. And it has become a burden and quite a burden. And so we are supposed to look at how this can be addressed. I was almost saying good evening, but if I say that, people will start thinking about the evening tea. So I'll stick to afternoon. So my presentation will be on cancer. Are in Kenya, and half of the 56.8 are in Africa. So that's the burden. According to this review again, barriers that are there when it comes to cancer care financing, cancer care policy and advocacy include the policies that we have, the training, lack of opioid access, and also infrastructure when it comes to prevention and care. So in 2019, globally, 68% of the countries were able to afford cancer care funding. But 40% of them report that this particular care is able to reach at least half of their residents. So the methodology, we did a narrative review, so synthesis of knowledge on cancer care financing, policy and advocacy. So the three were the main things that we are looking at, and we are focusing on the current efforts and trends globally but majorly in Kenya.